My name is Andrew Goldsweig, and I direct the clinical research program in the Heart and Vascular Center at Baystate Medical Center here in Springfield, Massachusetts, in the United States. We run clinical research programs for cardiology, cardiac surgery, and vascular surgery. And our academic partner is the University of Massachusetts. In the United States, the Food and Drug Administration approved left atrial appendage occlusion and provided basic guidance based on the early device trials, Protect AF, Prevail. That guidance, the data from those trials, have become somewhat outdated pretty rapidly. There's tremendous diversity in left atrial appendage occlusion practice regarding appropriate patients, regarding peri-procedural imaging, regarding adjunctive medical therapy, regarding management of peri-device leak and device-related thrombus in the post-procedure period. In that setting, to address the diversity in practice and the rapidly growing body of evidence, a left atrial appendage occlusion guideline was needed to standardize evidence-based practice and also to focus future research on important unanswered questions. I would posit that cardiology is the most evidence-based field within the House of Medicine. This particular endeavor was led by SCAI, the Society for Cardiovascular Angiography and Interventions, in partnership with HRS, the Heart Rhythm Society, which is the North American Electrophysiology Society. SCAI in general has begun to produce multiple guidelines using a very rigorous grade methodology. Previously, SCAI had produced a number of expert consensus statements, but formal guidelines really add a new strength to those recommendations. This left atrial appendage guideline is actually SCAI's third guideline, following the 2022 PFO guideline and the 2025 chronic venous diseases guideline. So SCAI partnered 50-50 with Heart Rhythm Society on this endeavor, with authors from around the world. This partnership is just a starting point with other SCAI and HRS collaborations already underway. In this case, the LAAO guideline panel consisted of 15 LAAO experts, including interventional cardiologists, cardiac electrophysiologists, also cardiac imaging specialists, and importantly, guideline methodology specialists. An extensive literature review and meta-analysis was conducted to answer 8 major specific questions in the field, formatted to put this guideline together. The nonprofit organization, the Evidence Foundation, was retained to help ensure the strictest adherence to the grade methodology. And then the guideline was recently published simultaneously in both JSCAI, the Journal of SCAI, and the Heart Rhythm Journal of the Heart Rhythm Society. One quick note on that as we're talking about methodology. Unlike many other societies' journals, JSCAI is open access, and I think that's a big deal because it allows clinicians and researchers all over the world instantaneous free access to this guideline document. So whereas many guideline documents published by other societies live behind paywalls and are difficult to access, and uptake and influence in the field may be slower, I think having an open access guideline document is a big deal. 7 key recommendations, and then some knowledge gaps identified. So first key recommendation, the guideline panel recommended LAAO over no therapy in patients with non-valvular atrial fibrillation for stroke prevention. Also recommended either LAAO or oral anticoagulation in patients with non-valvular AFib, with an equal emphasis on either therapy in appropriate patients and favoring LAAO in patients with contraindications to oral anticoagulation. Third recommendation, the panel recommended pre-left atrial appendage occlusion imaging with CT, computed tomography, or transesophageal echocardiography, TEE, to define anatomy and plan procedures prior to entering the procedural room. Number 4, recommended either intraprocedural TEE or intraprocedural ICE, intracardiac echocardiography, to guide left atrial appendage occlusion procedures. This is a new concept that has grown very rapidly, and this guideline synthesizing the data on outcomes with TE or with ICE makes the very important recommendation that either TE or ICE would be equally appropriate to guide these procedures. Number 5, the guidelines recommend short-term oral anticoagulation or dual antiplatelet therapy after left atrial appendage occlusion. The original approval of these devices just used short-term oral anticoagulation plus aspirin, and so bringing on dual antiplatelet therapy or DAPT as a co-equal is a big deal. The guidelines also favored DAPT in patients with particularly high bleeding risk. Number 6, the guidelines recommend post-left atrial appendage occlusion follow-up imaging with CT or TEE to assess for peri-device leak or device-related thrombus. And then the last 2 recommendations are a little bit more nebulous. For management of peri-device leak, the guidelines identify this as a key knowledge gap and promote research in this area to identify what constitutes a significant peri-device leak and how they should be managed, both medically and procedurally. And then the last recommendation is that for patients with device-related thrombus, oral anticoagulation is appropriate, but that there is a knowledge gap regarding the duration of oral anticoagulation and the timing of subsequent re-imaging to identify success and efficacy of oral anticoagulation. So that's a summary of the major findings of the SCAI HRS left atrial appendage guidelines. Left atrial appendage occlusion has exploded. Since the first left atrial appendage occlusion procedures in 2001, LAO has grown to become one of the most frequent procedures performed in cardiology. More than 100,000 LAO procedures were performed in the U.S. in 2024. Up to 20% of Americans experience atrial fibrillation in their lifetimes. And the number of individuals globally living with AFib continues to increase with the aging of the population in developed countries. Furthermore, due to ongoing research regarding the appropriate population for left atrial appendage occlusion, the number of eligible patients for these procedures may grow very rapidly in the future. So the challenge and opportunity together is the scale, rapidity of growth. In addition, LAO is the subject of very active research. The field is evolving rapidly. So the guideline document that we have today needs to be maintained, needs to be a living document. SCAI and HRS are committed to maintaining up-to-date guidelines. This guideline document, and particularly SCAI's pledge, is that all SCAI guideline documents will be updated regularly at a minimum every 5 years. Plenty left to learn and know about LAO that will affect future implementation of evolving guidelines. As we discussed earlier, there was no recommendation made regarding peri-device leak management. That's a knowledge gap that requires significant research. There have been only retrospective studies, registry-based studies, and single-center or small multi-center studies in that space. So a great deal more research is necessary to know how to manage peri-device leak, both medically with antithrombotic agents, how to survey it with imaging, which imaging modality, what timing, and potentially, for larger leaks especially, whether procedural closure is indicated. For patients with device-related thrombus, again, no recommendation made regarding oral anticoagulation duration or the timing of repeat imaging. That's an important knowledge gap that needs to be addressed. And then, saving the best for last, most importantly, the results from the Champion AF study are expected at the American College of Cardiology in 2026, ACC 26 in New Orleans. The results of the Catalyst study sometime in the future, hopefully not too far behind. These studies compare stroke rates and bleeding rates between left atrial appendage occlusion and anticoagulation in patients with atrial fibrillation and no contraindication to anticoagulation. So particularly Champion first on the docket. If Champion shows that LAAO may be safe and effective for essentially any patient with atrial fibrillation who requires stroke prevention therapy, the floodgates of LAAO will potentially open wide. The number of eligible patients could be huge because we said such a large percentage of individuals do experience AFib at some point in their lives. So we hope that the present guideline will provide high-quality evidence-based practice for a large number of LAAO patients at present, but that the present guideline will evolve with evolving evidence to continue to provide high-quality evidence-based practice for an even larger number of patients in the not-so-distant future.